Lameness is one of the most common reasons for which a pet owner will seek veterinary care, and yet confident localization and diagnosis of that lameness is actually one of the biggest day-to-day challenges that we face as veterinarians. You know, it's amazing how often I've wished that my patients would just give me 3 simple words, "It hurts here," as they point to the diseased or injured location on their limb. Little by little, I'm beginning to discover that more often than not, our patients actually want to tell us where it hurts if they trust us. And the question is, can we gain their trust, and will we hear them when they do their best to tell us where it hurts? You know, I continue to be challenged on almost a daily basis by those patients who present to me with what I perceive to be incredibly subtle orthopedic findings. I also have had an opportunity through the years to witness a great many orthopedic exams, whether it be an exam by a very inexperienced veterinary student or by some of the most seasoned veterinary practitioners. And through all of this, I'm beginning to explore the art of the meaningful orthopedic exam. It's so much more than a collection of palpation tests, the biceps traction test, the drawer test, the Ortolani test, the tibial compression test. Instead, I think the art of the meaningful orthopedic exam lies in our ability to gain the trust of our patients and to literally begin to understand them as they do their very best to articulate, "It hurts here." I think my first tip for a meaningful orthopedic exam would be to watch your patients when they don't know that you're looking, when they're totally unaware that you're interested in them. It might be while they're playing outside, as we're showing here, or sometimes I just like to watch my patient, the way they stand and the way they move as I greet the client, while we walk to the examination room, or while I'm taking a patient history. My next tip is strive to be their friend before you try to be their doctor. I learn my patient's name up front, and I use it as often as I can when I speak to them. I'm reminded of that old Far Side cartoon in which the pet owner speaks volumes to her dog, but the dog only recognizes her name. Blah, 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 Ginger, blah, 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 blah. Dogs like to hear their name. This Rottweiler patient is fairly skeptical of me, and so I'm going to take time up front to greet him by name. I'm going to use his name often. I'm going to pet him. I'm going to talk to him, because I think a few minutes invested into the relationship up front is going to save me a lot of time down the road as I try to get him to communicate with me what's bothering him. The more he trusts me, the more accurately he's going to convey what's going on. He's going to be less likely to either, squeal or tense up at every one of my orthopedic maneuvers, or to play the role of the stoic and hide from me his responses to my manipulations. So I'm taking the time to say his name, give him commands. He's beginning to get used to the fact that he's supposed to respond to my commands. And then our first physical interactions are all very, very positive. I think we need to remember that, my lab coat and my diploma on the wall, those don't mean a whole lot to my patient. Instead, it's the smell of my hand, it's the feel of my touch, it's hearing me speak his name. Those things are much more meaningful to this patient, and really, I think, to most of our patients.
Can you sit?
Well, I don't know with old Cato here whether you've noticed, but so far he's much more comfortable outdoors than he is in, and that brings me to my next point. I think we should seek our patients' comfort before we seek our own. Ironically, in the end, I think we'll be more comfortable if we do that. For years, I would simply grab my patients and lift them onto the exam table and start manipulating away. And, it's really no wonder that I had difficulty defining all but the most obvious causes of lamenesses when I did it this way. So now I'm going to try to consciously attempt to create an environment where my patient and I can relate to one another, in a setting that is comfortable to my patient and that there's not too much to distract either of us. So in the end here, if with Cato he's most comfortable outdoors, then outdoors is where we'll do our exam. You may have noticed that thus far none of the exams have been filmed with the pet owner present. I don't mind if a pet owner is present during the exam, and as you know, many pet owners are going to wish to be present during the exam, and if that's the case, I will certainly honor their request. If, however, I sense that the owner's response to my manipulations is beginning to make the pet nervous, and this happens fairly frequently, once I've gained the trust of the owner, I will later request a second exam done outside of their presence. In the context of patients' comfort before my own, I think most patients are most comfortable with me starting the exam with them in a standing position, and I do prefer to start the exam that way with them in a symmetrical stance. In this way, I can kneel behind the patient and use both of my hands to simultaneously palpate the thoracic limbs, then along the sides of the trunk and the spine, and down both pelvic limbs, and the patient's becoming more comfortable with my touch all the time. In doing this as well, take for instance palpating the tarsi, I'm much more able to detect small amounts of swelling, effusion, or warmth around one of the tarsi. If I were to examine just one tarsus at a time and then later examine the contralateral tarsus, it's fairly likely that I wouldn't detect the subtle asymmetric findings that may be present. Now, as I transition from feeling for asymmetry to performing specific manipulations on each limb, if the animal is more comfortable laying in a recumbent position, then that's how we'll position the pet. And essentially that's what happens here is this patient has been very content with a standing exam up to this point. But now it's my sense that there's some anxiety associated with it. I don't believe it's discomfort from the shoulder exam. And so again, patient comfort before my own. If this patient is going to be more comfortable in a laterally recumbent position, then let's complete our examination in that laterally recumbent position. My goal is for the patient to trust me enough that the patient again will say accurately, it hurts here, and I don't want to confuse anxiety for true physical discomfort. A similar question arises as to whether to perform the examination on an exam table versus on the floor. And I would say the majority of my patients are more comfortable on the floor than they are on the exam table. I will typically sit down on the floor as I learn their name and as I greet them, and you've seen that. As a result, I don't wear a lot of fancy clothes at work, but my patients don't seem to mind. As I'm petting them, I look for evidence that they're beginning to relax and trust me. And if they're comfortable on the floor, I'll gradually transition from petting to massage and then begin my palpation exam, somewhat as you've seen. Let's use our old friend Cato the Rottweiler as an example of all of this. First of all, notice I do have a muzzle on hand if I need it. However, he has, through kind of the transitions we've talked about, become a whole lot more comfortable to my handling. So I start out with what is petting, kind of massage down the sides of his trunk. I always have hands in contact with his skin. It's kind of a subtle transition, seamless transition from petting to an exam, feeling for asymmetry in his pelvic limbs. Now I'll kind of work my way up and be petting for asymmetry in his thoracic limbs. And then we'll gradually transition from this to more specific orthopedic exam. And he is so comfortable with my touch at this point. About the only thing he's uncomfortable with is the fact there's a cameraman in the room. So now that he does trust me, I should be able to detect a response to painful stimuli, assuming that we're free of other distracting stimuli, such as slamming doors and such. And you notice here, see there, he looks outside. And that was in response to a noise outside of the exam room. I should point out that while I am an advocate of not overdoing patient restraint, because I do want to see their response, we obviously do have to protect ourselves. And if the patient gives me any clues that his response may put me in danger, then I need to provide enough restraint to protect myself. Now, I'm very pleased with how successful we've been at putting Cato at ease for his exam. Nonetheless, I am taking some precautions with him. Normally for a thoracic limb exam in the standing patient, I'll be almost face-to-face with the animal so that I can see subtle changes in the expression of their eyes, etc. With a male Rottweiler who has expressed some anxiety over my dominance upon him, I'm not going to do that. And so I'm standing in a less aggressive position at his side. Even so, if I have any concerns whatsoever, because I am in a bit of a vulnerable position, I'll either put a muzzle on him or I'll have an assistant hold a slightly tensioned leash so that he's less likely to be able to swing around and take a bite at me. Well, I hope I've been able to share with you a few tips that you'll find useful on the art of the meaningful orthopedic exam, the premise of which is our patients will do their very best to tell us where they hurt if we can gain their trust. How? Well, We watch them when they don't know that we're looking. We strive to be their friend before we try to be their doctor. We seek their comfort before we seek our own. And we use lots of hands-on because we recognize that the exam doesn't need to be a lot different from the petting they receive from one of their trusted friends. Hi, today we're going to observe a 10-year-old neutered male border collie with very subtle lameness that is due to multiple abnormalities on the orthopedic exam. I think this patient will serve as a very good model for the challenge of detecting and localizing canine lameness. The goals of the lameness exam are first to classify the patient as sound, lame due to orthopedic causes, or ataxic/paretic due to neurologic causes. Another purpose of the lameness exam is to localize the lameness to the affected limb or limbs, and ultimately to grade the lameness. We typically use a 0 through 5 grading scale, but many lameness scales have been described. One of my tips is to observe the patient when they don't know that you're looking. This is a chance to see the animal as they move naturally about their environment, the way they shift their weight as they sit. Are they willing to rise normally? Are they willing to jump up on a chair or a bench? Are they even willing to put their paws up on the counter as they surf for treats? All of these give you clues as to what may be comfortable and what is not uncomfortable. We didn't have that opportunity for the filming of this patient, so the first step today is to acclimate the patient to the handler and to their environment. We're trying to get the patient to the point that they can move comfortably about the room with a symmetrical posture where they're not pulling on the leash, etc. I observe for symmetry of their gait. That is in regard to their stride length, their stride duration, and the way their limb moves through space. Are they circumducting their limb? Are they abducting or adducting their limb? Thoracic limb lameness is best observed as the animal is moving towards you. Look for a head bob or a head rise and try to get in sync with the dog's gait by saying up every time you see the animal's head rise. You can see how much easier it is to observe the patient when slow motion video is used, and this is available to you even on your smartphone. That said, even with slow motion video, this patient does not have a pronounced head bob. As the animal moves away from you, you can observe the pelvic limb gait. Once again, observing for stride length, stride duration, any circumduction to the gait, as we've described before. Additionally, look for a hip hike or a pelvic lift. Just as the head may rise to off-weight a painful thoracic limb, the hip may rise to off-weight a painful pelvic limb. Additionally, there can be a pronounced hip sway if there is discomfort within the region of the hips. For example, this dog seems to have a slightly pronounced lateral movement of the pelvis, the so-called hip sway. So I will be interested to see if there is any discomfort that can be localized to the region of the hips, the iliopsoas muscle tendon unit, or the lower lumbar spine. It is also helpful to have the animal move from side to side in front of the observer. This gives you a chance to watch each limb as it independently moves through space. It's a good chance to observe things like stride length. For instance, looking at the stride length of the pelvic limb may give us some clues, once again, regarding hip or iliopsoas discomfort. Dogs with discomfort in this region will oftentimes have a reduced stride length. Since dogs increase their stride length as they run, it can be helpful in dogs that have very subtle changes to their stride length to actually observe them as they run. Once again, using slow motion video will help to capture some of the observations that may be difficult to see because of the rapid movement of the patient. Observe the animal closely for lameness. Do you see a head lift? Do you see a pelvic lift? Do you see changes in stride length? Well, the good news is I don't believe this dog has obvious gait abnormalities that have been displayed thus far. There may be a very subtle decrease in hip extension during the terminal phases of the stance phase, that is, at the point of paw push-off, if you will. I like to observe the animal as they sit. Normally, an animal should be able to sit squarely. This involves maximal flexion of the stifles as well as of the tarsi. Reluctance to fully flex the stifles and tarsi can be indicative of pathology in either of those joints or perhaps both. Another trick that will help you detect subtle lameness is to observe the patient on stairs. Their weight is shifted to their pelvic limbs as they go up the stairs, and conversely their weight is shifted to their thoracic limbs as they descend stairs. This patient seems to have very little difficulty with the descent of stairs. However, when he's asked to go upstairs, he sometimes seems to be reluctant to push off, particularly with his right pelvic limb. My hands-on exam begins with the patient in a symmetrical stance, what I call my spandex exam, and this can be either at the beginning or at the conclusion of my general physical exam. But I'm running my hands symmetrically over the entire patient. I almost imagine that I've got eyes in my fingertips. I'm trying to detect any asymmetry, whether it's asymmetry in lymph nodes, whether it's asymmetry in muscle mass, joint effusion, tissue warmth. It really doesn't matter, but this is a perfect chance to pick up asymmetry. Now you may notice that I'm actually palpating very specific landmarks, and we're going to go through those in more detail as we talk about the individual limb exams. But here I'm working down the antebrachium, feeling the carpi for effusion, and then for swelling in the digits. Musculature of the thighs. Now I'm feeling the contours of the stifle, which we'll discuss, the Achilles mechanism, effusion in the tarsi and now down in the digits. Here are the popliteal lymph nodes. I'm going to palpate the patient's abdomen, so this can be that portion of the exam. And I'm going to take this opportunity to detect any spinal discomfort. And this dog does seem to be a little bit sensitive in his mid-lumbar spine and occasionally in his lower lumbar spine. I will then gently, but hopefully fully, move his tail into dorsiflexion, left and right flexion, and I'll do something similar with his head. Here, try to move his head to the right, and he's moving very freely. I'll move his head to the left, again moving very freely and without discomfort, all the way up and all the way down. Now we'll evaluate the individual limbs, and we'll start with the pelvic limbs. This can be done with the patient standing or recumbent. Really, it's a matter of how they're most comfortable. In most instances, I work from distal to proximal, so I'll begin by investigating the pads and the interdigital areas, again looking for trauma, foreign bodies, and as I evaluate each of the digits, I'll also feel for swelling and discomfort. And as you know, many dogs are going to be sensitive to digital palpation, but this is particularly problematic when it's more extreme in one digit than the others and is associated with swelling or warmth. Now I'm feeling the metatarsophalangeal joints and their associated sesamoids and running those joints through a full range of motion. I'll palpate the soft tissues and bones of the metatarsus, and then I'll work my way up to the tarsus. So I want to evaluate the tarsus for full extension and full flexion. Here you can place the dorsum of his paw really up next to his tibia. It's got very good range of motion. And out into nearly 180 degrees of extension. Then I will go ahead and test him for instability in varus and valgus. With the tarsus fully extended, that tests the long components, and then I'll do the same with the tarsus in flexion, and that tests the short components of the collateral ligaments. I'll feel for joint effusion, and typically I'm feeling in the region between the malleoli, in this case the lateral malleolus, and the tubercalcis. And that region between those is where I typically can feel effusion. Here I'm stabilizing the calcaneus, and I'm feeling for instability in the proximal intertarsal joint, or the calcaneocordal joint. I can feel the Achilles mechanism as it inserts on the tubercalcis, and normally I can feel too of the 5 components of that Achilles mechanism. Now I'm feeling the soft tissues and bone of the tibia, feeling for discomfort, swelling, etc. Evaluating the stifle in full flexion, as well as in extension. And even in the normal healthy stifle, on occasion, forceful extension of the knee will elicit some discomfort. While the knee is extended, I can test the collaterals medially and laterally. Next, I can perform the tibial compression test, or what some people call tibial thrust, as a test for cranial cruciate ligament incompetence. I'll place my thumb behind the lateral fibula and my finger on the tibial tuberosity, and I'll squeeze those together. I call these my X-cap fingers because they course along the same pathway as an extracapsular suture. As I squeeze them together, I then flex the tarsus while holding the stifle in a standing angle. This generates tension within the gastrocnemius mechanism, and in the cruciate ligament incompetent knee, you will feel the X-cap sutures stretch out, that is, the tibia displacing forward. I sometimes find that the drawer sign is easier to elicit with the dog in lateral recumbency, so I think that's what we'll do today. So let's evaluate now the bone and soft tissues of the thigh. So here, palpating up the femur, palpating the hamstring muscle group, now going to range of motion of the hip, so we can fully flex the hip. The femur is essentially parallel to the lumbar spine, and gradually I can extend the hip, although the dog does seem a bit reluctant to that. Now that can be behavioral in a dog who's a bit tense, but also can be a sign of discomfort, and so that's going to take some discernment on your part. So that said, I'm a little bit suspicious of hip discomfort, but certainly it could be in the low lumbar spine or it could be in the iliopsoas region, so we'll keep going. Here I'm abducting the hip, and the dog seems, again, a little bit uptight about that, but is certainly permissible a full hip abduction. So to evaluate the iliopsoas muscle group, we will combine hip extension with internal rotation, and that elicits discomfort. And so there I'm highly suspicious that he still has some iliopsoas discomfort. The iliopsoas runs along the ventral surface of the lumbar spine and inserts on the lesser trochanter on the medial side of the proximal femur. So by combining hip extension with internal rotation, I was putting that iliopsoas muscle group under tension. Here, as I palpate the insertion of the iliopsoas, I can actually detect some spasm, and again, he seems a little bit uncomfortable to this maneuver. I also performed a rectal exam, although that doesn't actually make great video, but what I was looking for was discomfort as I swept my finger along the brim of his pubis. And lo and behold, what I did discover was that, yes, he did have discomfort more so on the right pubic rim than on the left pubic rim, again, consistent with iliopsoas discomfort. Then let's go ahead and move to the recumbent exam. I don't always do both a standing exam and a recumbent exam, but I think it's worthwhile to show you each. So we'll begin once again by examining the pads and between the pads. Then I'll palpate the digits, especially for thickening. If there is thickening or discomfort, it's worth palpating for instability. Next, I'll palpate for swelling and discomfort in the metatarsophalangeal joints and their associated sesamoids. Then I'll palpate up the metatarsal bones. Then I'll evaluate for tarsal flexion, as well as extension. We'll feel for a fusion between the lateral malleolus and the tubercalcis. Then we'll test for collateral ligament instability with the tarsus and extension, testing the long components. And then we'll test again for varus and valgus instability with the tarsus flexed. And this is testing the short components of the medial and lateral collaterals. Then I'll palpate the Achilles mechanism insertion on the tuber calcis, and it has no swelling, no discomfort, and I can actually feel 2 of the components of the Achilles tendon. Then we'll palpate the tibia and the surrounding soft tissues up to the level of the stifle. The stifle will test for full flexion as well as full extension. We can test for collateral ligament instability with the stifle and extension, so we can apply a valgus stress to test the medial collateral ligament, and we can apply a varus stress to evaluate the lateral collateral ligament. And now we'll evaluate for cruciate ligament instability. To do that, we'll use the tibial compression test to evaluate for cranial tibial thrust instability. To do so, I'll place my thumb behind the lateral fibula and my finger on the tibial tuberosity. And these are my X-cap fingers, and I'll squeeze them together like an X-cap suture. And with the stifle held in a standing angle, I will flex the tarsus to create tension within the gastrocnemius mechanism, which will compress the sloped surface of the tibia against the femoral condyles. And in the cruciate deficient stifle, you will feel cranial tibial displacement. We can also do the drawer test. To grasp the femur with my proximal hand, I will place my thumb behind the lateral fibula and my finger on the patella. To grasp the tibia with my distal hand, I will place my thumb on the fibular head, and I'll try to roll the fibular nerve off of the fibular head, and my finger will be placed on the tib tube. And I will stabilize the femur with my left hand while I attempt to create a drawer motion with my right hand. And this should be done in extension as well as in flexion. On the inset, you see a cranial cruciate deficient knee. Then we will palpate up the femur, and we'll feel the soft tissues of the thigh, including the quadriceps group in front, the hamstring group in back. And then we'll assess passive range of motion, and I usually start with hip flexion. The femur is now parallel to the spine, and we'll go slowly into hip extension. Now, anxiety can limit the amount of extension, so go nice and slow. And if there is some resistance to hip extension, as we're encountering, that could be hip joint, could be lower back, could be iliopsoas, or some combination thereof. Next, we'll abduct the hip, and oftentimes dogs with hip joint discomfort will resist this, as he is. So he may well have some hip joint discomfort. And we previously evaluated his iliopsoas by combining hip extension with internal rotation and found that to be quite uncomfortable, so I don't think we need to repeat that. To evaluate for the possibility of a traumatic hip luxation, we can use the triangle test, which involves palpable identification of the ischiatic tuberosity, the greater trochanter, and the dorsal iliac spine. And notice that these form a shallow triangle in the normal hip. When there is a dorsal luxation, these 3 points will often form a line. The thumb pinch test can also be used to evaluate for traumatic hip luxation. Start by palpating the greater trochanter, palpate the ischiatic tuberosity, and place your thumb between them. In the normal hip, your thumb will be pinched between the greater trochanter and the ischiatic tuberosity as the hip is externally rotated. And that's what I'm feeling here because this dog, of course, does not have a traumatic luxation. Neither the thumb pinch test nor the triangle test, which are used to detect traumatic hip luxation, should be confused with the Ortolani maneuver. Now, the Ortolani test is used to evaluate for hip joint laxity. To perform the Ortolani maneuver in the laterally recumbent patient, I will place my hand along the dorsum of the pelvis. The hip is held in a standing angle. Then I will create a force directed up the axis of the femur, and if there is laxity in the hip, it may subluxate, but I don't always feel that at this stage of the maneuver. But then I will gradually abduct the hip, and feel for reduction of the femoral head. Then I slowly adduct the hip until the femur is back in the normal position, and I feel for subluxation as I do so. Now, for this elderly patient with hip pain, I don't think we need to repeat that particular maneuver. If there were associated discomfort, obviously this maneuver could be performed with sedation if it were indicated. So now let's move on to evaluation of his thoracic limbs, and this can be done with the patient standing or recumbent. Depending upon the temperament of the patient, I may stand at the front like I'm doing here. Other times I may stand at the patient's side. Once again, we'll begin at the digits, and I'm palpating between the digits as well as looking at the pads themselves for evidence of trauma. I didn't mention it with the pelvic limbs, but sometimes, particularly in greyhound breeds, you can see pad corns or warts as a cause of lameness. Each of the phalanges, now I'll direct my attention to the metacarpophalangeal joints and their associated sesamoids. We'll run those joints through a range of motion, and then we can palpate up through the metacarpus, both soft tissues and bony tissues. We'll feel for carpal effusion. I'll run the carpus through a range of motion. For an older guy, he's got great carpal flexion, can put his pads on the back of his antebrachium, has full carpal extension, and that's pain-free. We can test him for varus and valgus instability. Notice that in the carpus, especially this flexed carpus, they have this funny drawer sign. That's actually normal. Now I'm palpating the accessory carpal bone and the insertion of the flexor carpi ulnaris upon it, feeling for swelling, much like you were feeling the Achilles mechanism inserting on the tuber calcis of the pelvic limb. Working my way up the soft tissues and bone of the antebrachium, and now getting to the region of the elbow. So here's his lateral epicondyle. There's the olecranon. And when I'm feeling for effusion, I usually feel for it between those two structures. So right about where my thumb is where I would feel for effusion. That feels good. Now I'm going to assess range of motion. He's got full, pain-free elbow flexion. He can place the point of his shoulder against his distal antebrachium. And I'll evaluate him for discomfort on extension. If I'm too forceful, I can make a dog with a healthy elbow uncomfortable on forceful elbow extension, but he seems fine. And now we'll promenate and supinate him by placing his carpus in 90 degrees, his elbow in 90 degrees. And I'll pronate, and I will supinate. And that doesn't seem to be uncomfortable to him. As I feel his humerus, I have to be aware that his radial nerve courses right through his musculospiral groove, or in that region. And so if I'm too forceful as I squeeze on his humerus, in that region, it may be that I'm just pinching his radial nerve. Feeling his triceps. So now we can extend his shoulder, recognizing that his shoulder is extending and his scapula is gliding along his thorax. And now we'll flex his shoulder, and that's very uncomfortable. And so that is suggestive of a tendinopathy, whether it be supraspinatus, biceps, don't know just yet. Now we're going to externally rotate his shoulder, internally rotate his shoulder. And now we'll do the biceps traction test. And we'll do that by placing his shoulder in flexion as we gradually extend his elbow. That begins to stretch out the biceps tendon. And I'm going to feel over the region of his biceps tendon origin on the medial side of his greater tubercle. And that's uncomfortable to him. And indeed, he has been treated for a biceps tendinopathy in the past. And while his gait has improved under that physical therapy regimen, he does still have some biceps tendon discomfort. He has also been treated for an insertional tendinopathy of his supraspinatus tendon, the muscle group on the cranial aspect of the scapular spine that comes down and inserts here on the greater tubercle. At times in the past, he's had insertional discomfort on the greater tubercle, but today that does not seem to be associated with discomfort. And now we'll palpate deep in his axilla, and this can sometimes be used to detect axillary masses. So this is the region of his pectoral muscle group, passing from his sternal area to his proximal humerus. And I'm going to place my thumb up behind the pectoral muscle group, and my fingers are actually going proximal to the pectoral muscle group as they span the region. And with this, I can feel deep up in his axilla. And he's got no evidence of discomfort or space-occupying masses in this region. Now let's do a recumbent exam of the front limb. Note that we have our patient on a padded raised platform that allows me to sit alongside the pet on a rolling stool. And this is a nice solution for those of you who have some mild to moderate mobility issues of your own. Now at this point, there's really no difference than what I've shown you previously to date. I'm palpating the pads, in between the pads, palpating the digits, etc. We'll feel the metacarpophalangeal joints, palpate the metacarpus, assess range of motion in the carpus as well as the elbow, etc. What I did not show you during the standing exam is how to measure the shoulder abduction angle as a means to evaluate for medial shoulder instability. For this exam, it's important to be able to palpate the scapular spine so that you can hold the scapula stable against the body wall. Now position the shoulder into full extension. Then slowly abduct the shoulder. Now this can be an uncomfortable maneuver, even in patients with a healthy shoulder, so be sure to go very slowly. And remember, it really is an instability test. A painful response is not necessarily relevant or significant. Instead, I will assess the abduction angle and compare that of the right shoulder to the left. The abduction angle is the angle formed by a line drawn parallel to the table's surface and a second line drawn down the axis of the humerus with the shoulder held in maximal abduction. Now you can actually use a carpentry app on your smartphone to help measure this angle. Now when I get an abduction angle that's greater than 45 degrees, I start to become concerned about medial shoulder instability. This is especially true if the abduction angle is 20 or more degrees greater than the contralateral asymptomatic shoulder. Now there's 3 points of emphasis that I want to make. First, as I previously stated, it's important to stabilize the scapula. If I don't stabilize the scapula, abduction of the limb causes the scapula to merely glide along the chest wall. Second is, if I do hold the scapula down, but I allow his shoulder to flex, even normal dogs will have a very large abduction angle. Third is if pain is preventing you from performing this maneuver as precisely as you'd like, that may be an indication for sedation, and this can be combined with relevant diagnostic imaging. To palpate deeply into his axilla in this position, his pectoral muscle group's right here, and I can slide in behind his pectoral muscle group, in this case with my thumb. On the opposite shoulder it would be my fingers, but I'm feeling for masses as well as areas of discomfort up in the area of his brachial plexus. And you can see that with my fingers I'm able to reach over the top of his pectoral muscle group, and I'm able to reach approximately halfway up the medial surface of his scapula. So I'm getting a really nice deep palpation up in this axillary region. Well, thanks a lot for spending some time with me, and I hope that you have found this video helpful. Now here's a tip you may wish to consider for analyzing the gait of small breed dogs, is use of a selfie stick and smartphone to film the gait from the side as well as from behind or in front of the dog. We all know that small breed dogs, it's difficult to get down at their level to visualize their lameness, and the selfie stick can certainly help in that regard. Another challenge with small breed dogs is the rapidity with which they move their limbs. Again, by using the selfie stick to capture the video and then taking the video and putting it in slow motion, we can oftentimes see a great deal more detail regarding the dog's gait. We're going to take a look at a 10-month-old golden retriever that has been lame on her right front limb for 6 months. The breeder suggested the lameness was most likely due to growing pains, probably referring to panosteitis. It is important, however, to point out that panosteitis typically causes a lameness that shifts from limb to limb over time, and that was not characteristic of this dog's lameness. At a stance, we note that the dog typically will stand with the right front paw rotated externally. This is a relatively common stance posture for dogs with medial elbow pain. Next, we're going to take a look at the dog's gait when viewed from the left side. It is worthwhile to point out that all of these videos were shot with a smartphone and a selfie stick, so this is not very sophisticated equipment. Yet it gives us very good analysis of the dog's gait. During the observation of the gait, we can see that there is a subtle head-bobbing lameness. Slow motion video is typically available on most smartphones as an app or even as an inherent feature of the phone itself. It can be really helpful in determining which side is most affected by the lameness. And here we can see the dog is willing to bear weight on his left thoracic limb, but tends to lift his head on the right thoracic limb. So head goes down on left, up on right, down on left, up on right. And the saying is down on sound. They're willing to bear weight on their sound limb. I like to view the gait from multiple perspectives, and in this case viewing the lameness from the front, again using a smartphone and a selfie so I can get down at the level of the dog, gives us a much better view of the lameness, and it's very clearly a right thoracic limb lameness on this view. Slow motion video can also be helpful in client education because sometimes the owner is very convinced that the lameness, perhaps in this case, is the left front limb. And by showing slow motion video, I can characterize and justify exactly why I say the lameness is in the right thoracic limb. With regard to the assessment of possible panosteitis, we should point out that on exam there was no pain detected upon deep palpation of the long bones. Here I'm evaluating passive range of motion of the left elbow, and there is a full range of motion present, with only very minor discomfort noted upon extremes. Next, we'll direct our attention to the right elbow, and I should point out that I'm only showing the elbow exam, but a complete exam of each thoracic limb was performed. On full flexion, actually, the dog rolling over may well have been an attempt to avoid full elbow flexion. Here, discomfort is noted on forced elbow extension, but even more significant to me is the discomfort noted on forced full flexion of the right elbow. I should point out that while the patient's responses seem relatively mild, one of the reasons that I'm comfortable attributing them to pain is that I performed these maneuvers on multiple occasions rather than relying upon the patient's response to a single stimulus. So in the end, I was quite confident in my assessment that the patient had a grade 3 out of 5 right front limb lameness that localized to the right elbow. Next, I reviewed radiographs made by the primary care veterinarian to screen for the presence of panosteitis, as well as to look for other explanations of the lameness. On this radiograph of the left elbow, which is relatively asymptomatic, I see no evidence of sclerosis within the intramedullary canal of the diaphysis, as one might expect with panosteitis. But I do see very subtle sclerosis in the region below the trochlear notch adjacent to the medial coronoid process. This is indicated by the arrow. We'll compare these radiographic findings to radiographs of the right elbow, the more clinically affected of the limbs. Again, we see no evidence of panosteitis on this film. However, if we direct our attention to the region below the trochlear notch adjacent to the medial coronoid process, once again, the appearance of sclerosis is apparent, and it's more pronounced in the right elbow than the left. With this information in hand, we sought to get more detailed information regarding probable medial coronoid process disease with a CT scan. Here we can see fragmentation, perhaps in situ fragmentation of the medial coronoid process along the radial incisure of the medial coronoid process, adjacent to the radial head. On transverse slice imaging of the same right elbow, again we can see the evidence of in situ fragmentation along the radial incisure of the medial coronoid process. With this imaging of both elbows, we made a diagnosis of bilateral medial coronoid process disease, but with fragmentation of the right medial coronoid process that coincided with the right thoracic limb lameness. And while the diagnostic imaging and its interpretation is certainly interesting, in actuality, the lameness diagnosis for this dog all began with a good examination of the dog's gait and then orthopedic palpation. Hi, in this video we're going to take a look at a couple of patients with fibrotic myopathy of the gracilis and/or semitendinosus muscles. This condition most commonly affects German Shepherds between 3 and 7 years of age, and as you can see on the gait of this patient, the lameness is characterized by its presence being in the forward swing phase of the gait cycle. Notice that there's a sudden internal rotation of the tibia, and in some patients, there's an apparent sudden stifle flexion and foot stomping gait when viewed from the side. You'll see that better in our second patient. As you look at this patient in slow motion, you'll see not only is the presence of the gait abnormality in the forward swing phase, it's particularly pronounced during the terminal portions of the forward swing phase. And this occurs because the fibrotic myopathy of the gracilis or semitendinosus is drawing taut at that phase of the gait. Let's take a look at our second patient. Once again, it's a German Shepherd, and notice this dog, when viewed from the side, has more of that sort of foot-stomping gait where during the terminal phases of the swing phase, suddenly the stifle is drawn into flexion and the foot is stomped down hard against the ground. When viewed from behind, you can once again see the profound internal rotation of the tibia that occurs during the terminal portions of the swing phase. Now, once that you recognize the kind of the characteristic gait, on physical exam you'll notice or palpate a taut band that restricts stifle extension when compared to the contralateral limb. The condition tends to be non-painful, at least at the point of fibrous tissue maturity. It can affect either the gracilis or the semitendinosus, or in some cases both. Rehab may have some value early in the disease process, but is more questionable value once fibrotic myopathy has matured. Surgical transection or even resection of the fibrous top band does not appear to be of value because recurrence is the norm following this procedure. As I think you can appreciate, if there's one diagnostic tip I would give you, it would be that if you see a gait that you believe is characteristic of this condition, go ahead and video it and use the slow motion video feature to really critically assess the gait cycle. The good news is it is not a painful condition, but admittedly it can be a debilitating condition for the working dog. Hi. Today you're going to learn about infraspinatus contracture. This is a condition that commonly affects medium-sized hunting dogs. While it most commonly affects them unilaterally, it can, as in our patient today, affect them bilaterally. Note the characteristic circumducting gait that occurs during the forward swing phase, and there's also often an associated carpal flip sort of appearance. Though it may not be a perfect description, some describe this as a floor scrubbing gait. The good news with this particular contracture is that if the infraspinatus tendon can be completely transected and released from the underlying shoulder joint capsule, normal limb use can be restored. Hi. Let's take a moment to learn about partial Achilles tendon disruption, so-called type 2C Achilles tendinopathy, which is due to incompetence of the gastrocnemius tendinous insertion on the tubercalcis. Let's also learn how it can be distinguished from that of a complete disruption of the Achilles mechanism. Degeneration, tearing, and/or stretching results in palpable swelling of the insertion on the tubercalcis. The condition most commonly affects middle-aged, often overweight Labrador retrievers and/or Doberman pinschers. After the onset of swelling, there's oftentimes a progressive pelvic limb posture change, characterized by increased stifle extension, as well as an increased but partial plantigrade stance of the tarsus, but with a concurrent crab claw posture of the foot that indicates the integrity of the superficial digital flexor component of the common calcaneal tendon. It is the chronic and progressive nature of the problem, combined with the partially plantigrade stance and the concurrent presence of the crab claw posture, that distinguishes this condition from an acute, complete traumatic disruption of the Achilles mechanism. Early treatment is often preferred and ranges from support and a custom orthosis, plus or minus the presence of orthobiologics such as platelet-rich plasma or stem cells, to various surgical options, depending upon the severity of the condition, the pet's lifestyle, and surgeon preference and experience. Thoracic limb lameness can be frustrating to evaluate, and doctors must always be aware of the potential of non-orthopedic causes. Diffuse muscle atrophy is noted within the limb, therefore making disease or injury of the brachial plexus a consideration. The patient's ability to flex the elbow using the biceps muscle suggests some functional integrity of at least the cranial portions of the brachial plexus. The cutaneous or panniculus reflex is a twitch of the cutaneous muscle in response to a cutaneous stimulus. The sensory nerves from the skin enter by way of the dorsal root. The ascending pathway is probably the same as for superficial pain. The synapse occurs at the C8-T1 segments with motor neurons of the lateral thoracic nerve that innervates the cutaneous trunci muscle. As such, assessing the motor arm of the panniculus reflex can be helpful in the assessment of patients suspected of brachial plexus injury or disease. Here, the patient has apparent sensory input on both the left and the right side. However, the motor arm of the panniculus reflex is apparently only present on the patient's right side. In this patient, Loss of sympathetic stimulation caused by disease of the T1 through T3 roots of the left brachial plexus causes subtle left-sided meiosis and ophthalmos and ptosis characteristic of Horner's sign. The combination of findings in this patient is strongly suggestive of a neurologic rather than an orthopedic cause of the lameness. Specifically, disease of the caudal portions of the brachial plexus is suspected. The diagnosis can be confirmed with a combination of EMG, MRI, and surgical exploration. Ultrasonographic imaging can also be useful in selected cases. Let's take a look at a boxer patient with a very obvious left pelvic limb lameness. And in addition to localizing the lameness to that limb, we'd like to better localize it to a specific region on that limb. And we see the patient centering his center of mass to the right side of his body. We also see that when the patient sits, he seems to not only shift his weight away from the left pelvic limb, he seems to intentionally avoid flexion of the stifle and/or tarsus. So the positive sit test has been described, and oftentimes people regard it almost as pathognomonic for stifle disease. While certainly it can be seen in dogs with stifle disease, it can also be seen in patients with limited flexion in their tarsus. Here you can see two characteristic postural adaptations. The patient has dramatically shifted his center of mass to the right side. You can also see intentional avoidance of stifle and tarsal flexion. Note that the force of stance is exerted entirely through the right pelvic limb. Hi, let's take a moment to look at a few patients with bilateral craniocruciate ligament disease and characterize their gait as well as their sit test. Here you see a patient with her head held very low and her thoracic limbs pulled caudally so as to shift her center of mass toward her thoracic limbs and away from her pelvic limbs. When asked to sit, she employs a similar strategy to protect her hind limbs from excessive loading. She not only does all the work of sitting with her thoracic limbs, but she carefully avoids full flexion of her painful stifles. With time, this compensatory response will cause her to develop significant atrophy of her pelvic limbs and large shoulder muscle mass. Here's another patient with bilateral cruciate ligament disease who extends her neck forward and pulls her thoracic limb backwards, almost to be a teeter-totter to unweight her pelvic limbs, and once again, certainly doing her best to avoid full flexion of her stifles that are quite uncomfortable. Hi, today let's talk about the use of diagnostic joint blocks, something that we use with relative frequency to distinguish shoulder from elbow lameness. So here's a patient that presents to us for a right thoracic limb lameness. So let's study this patient at regular gait speeds as well as at slower gait speeds. There's a relatively obvious head bobbing lameness, though at this gait speed it may be difficult for some to distinguish whether it is the right thoracic limb or the left thoracic limb. I oftentimes recommend that you try to get in sync with the patient's gait by saying up when you see the patient's head rise. Up, 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 up. Now that's much easier to perform when we slow the gait down here 25% of the normal speed. Up, 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 up. As you perform this exercise yourself, I think you'll convince yourself that this patient has a grade 3 out of 5 right thoracic limb lameness. Unfortunately, we got mild but repeatable pain responses upon manipulation of both the right elbow and the right shoulder. We were therefore unable to differentiate which was the source of the lameness. The patient was sedated and carbocaine was administered in the right elbow. The sedation was reversed 20 minutes before the following videos were filmed. We will once again look at the patient's gait both at the normal speed as well as slowed down into slow motion. But already it is evident that the obvious head bobbing lameness is either resolved or significantly improved as compared to that prior to the joint block. As a side note, I will oftentimes randomize the video clips and ask those, including the pet owner, who are uninvolved in the administration of the joint block, to rate the lameness on each of the film clips. When there is a positive joint block, it's not unusual for the owner to say, "Well, if my dog always looked like that, I'd be very happy." So our observations were that this patient was significantly improved, perhaps not completely resolved, but significantly improved by the administration of the joint block in the right elbow. So let's talk just a little bit about what's reported about diagnostic joint blocks and common protocols that may be used. Various sedation protocols are used, ranging from no sedation at all. I think one has to be quite good with their joint tap technique if you're not using sedation, to neuroleptalgesia, to what we most commonly use, which is a reversible sedation using dexmedetomidine. This requires the use of less restraint and seems to be associated with less pain of administration of the joint block. It should be noted that joint blocks are only of value when there's a relatively obvious lameness, grade 3 out of 5 or higher. Intra-articular corticosteroids could be used in instances of milder lameness, provided that infection has been ruled out, but then the owner would essentially be required to make observations as to whether the lameness was improved or not. So again, since joint blocks are dependent upon seeing an improvement in lameness, it really is only of value with obvious lameness. Our typical protocol is to perform a pre-treatment video evaluation, administer reversible sedation, commonly dexmedetomidine, during which time imaging and palpation tests such as shoulder abduction angle can be performed, and then the joint block is administered. There's a variety of options of analgesics that can be administered intra-articularly. We most commonly use mepivacaine, brand name carbocaine. We then reverse the sedation as soon as possible and perform our post-treatment video evaluation once the patient has fully recovered from their sedation, usually about 20 minutes following the reversal. I commonly randomize the video clips and ask those who are blinded as to whether or not the patient has received the block or not for a given video clip to rate the lameness. If these blinded observers commonly assign an improved lameness score to those videos that were performed after the joint block, I'm relatively comfortable in localizing the lameness to the blocked joint. Use of carbocaine to block joints has been reported at the dosages listed. The lag time to the onset of response has been reported as being between 2 to 25 minutes, an average of around 8 minutes. It's also important to keep in mind that while improvement is common, an 85% response rate, full resolution of the lameness should not necessarily be an expectation. And always keep in mind that there is the possibility of a false negative response. Thus, the absence of a response to the joint block could be due to any of a host of reasons, including an inaccurate administration of the joint block itself. And this brings me to the final point. It's important to learn how to aseptically, safely, and efficiently perform joint taps and administer intra-articular injections. And that's the topic of another one of our video series that you can see listed here. All right, now I'm going to give you a case challenge. This is a young adult Labrador Retriever hunting dog presenting to you for a right front limb lameness. Notice the circumducting gait during the forward swing phase, and there's also a little bit of a carpal flip. This condition most commonly affects athletic, medium-sized dogs, oftentimes working dogs or dogs who are actively engaged in hunting. At this stage of the disease, the condition tends to be non-painful. At a stance, one may notice the limb being abducted at the level of the shoulder with external rotation of the distal limb, though in my opinion it is most easily seen during the swing phase of the gait. This patient's left shoulder shows normal musculature and normal freedom of internal rotation of the shoulder joint, even as the scapula is held firmly against the thoracic wall. In contrast, in the patient's right shoulder, that is the abnormal shoulder, we see atrophy of the spinatus muscles, particularly the infraspinatus muscle, and notice the restriction to internal rotation of the shoulder, particularly as the scapula is held firm to the chest wall. In essence, the humerus and scapula are wanting to move as a unit, particularly in regard to internal rotation. Even as the limb lies at rest, you can see abduction at the level of the shoulder and that characteristic external rotation of the distal limb. So all of these findings are the result of infraspinatus contracture. And the good news is this can be effectively treated with infraspinatus tendinectomy and release of adhesions between the infraspinatus tendon and the underlying joint capsule. My rule of thumb when performing the tendinectomy is that if I think I've completed the tendinectomy, I probably actually haven't. But if I know I've completed the tendinectomy, then I'm certain that I have. And I think you'll see what I mean here. This looks pretty good, but then it appears that there may be just a small remaining portion of tendon. I'm not confident that I've got a complete release. Now we go back to this area. Now I know I've completed the tendinectomy. At this point, I'll also go back and I will remove about a 1 centimeter section of the tendon. But you can see complete rotatory freedom of the shoulder joint now that the tendon has been completely transected and released from the underlying joint capsule. Today I'm performing the cranial drawer test under general anesthesia as part of our standard protocol before entering into the operating room for surgical stabilization of this right stifle. I'll begin by placing my thumb on the fibular head. As I do that, I'm going to roll the soft tissues, including the fibular nerve caudally, away from the fibular head. Next, I'll place my finger on the tibial tubercle, capturing the right tibia within my right hand. Now I'll place my left thumb behind the lateral fibula, again rolling the soft tissues off of it. And finally, I place my left index finger on the patella, again isolating the femur within my left hand. Now I'll use my left hand to stabilize the femur as I translate the tibia cranially and caudally with my right hand. I'll do this with stifle and extension as well as in flexion. Increased instability in flexion is typical of a partial cranial cruciate ligament tear. And in this patient, I can feel a soft end feel upon cranial tibial translation or cranial drawer sign. But I feel a very firm or hard end feel, a very distinct end point, upon caudal tibial translation or caudal drawer, suggesting integrity of the caudal cruciate ligament. And that is a wrap. Here I will demonstrate the tibial compression test. It is a test for cranial tibial thrust instability. As I hold the stifle in a standing angle, I place my thumb behind the lateral fibula and I place my finger on the tibial tuberosity. And I'm actually going to squeeze these points together like an X-cap suture to reduce any cranial tibial displacement resulting from cranial cruciate ligament rupture. Now, with my left hand resembling an X-cap suture and the stifle held in a standing angle, I'll use my right hand to simulate weight bearing by flexing the tarsus. As I do so, you can see the cranial tibial translation that occurs with tarsal flexion. Additionally, this patient has internal rotational instability of the stifle upon the tibial compression test. Hi, today we'll be performing the Ortolani test as a measure of passive hip joint laxity in a patient being prepared for a left triple pelvic osteotomy. The patient is in right lateral recumbency and the hip is being held in a neutral position, neither in extension nor flexion, neither internally nor externally rotated. The examiner's right hand is placed upon the dorsum of the patient. As a force is applied with the left hand, which is cupping the stifle, the force is being applied up the axis of the femur. As that force is applied, subluxation occurs initially, though it is oftentimes not palpable. As the force is maintained, the hip is abducted until reduction is felt here at approximately 25.8 degrees. The force is maintained up the axis of the femur until subluxation recurs. Let's show this again with slow motion. So this patient has a very distinct positive Ortolani sign with an angle of reduction of 25.8 degrees and an angle of subluxation of approximately 0 degrees. In the juvenile stages of canine hip dysplasia, patients' hips will subluxate dynamically. Now here's a test you've probably never heard of. Rather than using the Ortolani test as an indirect assessment whether or not you can induce hip subluxation, why don't you use a more direct assessment, the bookend test, to determine whether or not the patient who's standing in front of you indeed has subluxated hips. One clue that the hips may be subluxated is the prominent greater trochanters, as you see here, creating a boxy conformation to the hind end. The bookend test involves applying a lateral to medial pressure on each of those greater trochanters to see if you can reduce those dynamically subluxated hips. This French bulldog has the boxy conformation that suggests bilateral hip subluxation, and indeed here you can see reduction of the right subluxated hip. By relieving the pressure, the hip subluxates once again. Sometimes I will sway the dog's pelvis back and forth to create the recurrent subluxation. The bookend test is not typically painful. Hi, in this video you're going to learn to measure shoulder abduction angle as a means to detect medial shoulder instability. This maneuver can be performed in the awake animal. However, if there is discomfort and I'm highly suspicious of medial shoulder instability, I may well repeat the maneuver with the animal sedated, and this is oftentimes done in conjunction with diagnostic imaging. So here we have an animal who is sedated actually on a radiography table. The shoulder is held in full extension, while with my left hand I'm holding the scapula firmly against the chest wall as I abduct the shoulder to its maximal extent. This can then be measured with a goniometer or a Carpenter app on a smartphone, as is being performed here. This measured shoulder abduction angle and the character of the end feel of maximal abduction is compared to the contralateral limb. Any shoulder abduction angle greater than 45 degrees, especially if the difference relative to the normal shoulder is more than 20 degrees, is considered suspicious.